Good afternoon, everyone. I am Dr. Beatrice Greenstein. I am the president of the IAS, the International AIDS Society, and I'm also the director of the HIV-STI Clinical Trials Unit at the National Institutes of Infectious Diseases, Evandro Chagas, Fiocruz, in Rio de Janeiro, Brazil. Welcome, all of you, to IAS 2025, the 13th IAS Conference on HIV Science. The IAS Conference on HIV Science is the world's most influential meeting on HIV research and its applications. IAS 2025 is taking place in Kigali, Rwanda, and virtually at a critical moment for the global HIV response. It's deeply significant that this conference is taking place in Africa, the region most affected by HIV and where the impacts of funding cuts are being felt most acutely. Our press conference today is titled Breakthroughs Amid Crisis, the Future of HIV Innovation. Today marks a significant moment in the journey to expand choices and improve outcomes for people living with and vulnerable to HIV. New WHO guidelines, groundbreaking licensing agreements, and promising research signal that long-acting HIV prevention and treatment are moving closer to becoming part of everyday care. This is a testament to what's possible when researchers, industry, global health institutions, and communities work together. Our next challenge is clear. Leaders must commit the funding and resources needed to integrate these scientific advances into health systems quickly and equitably so that people everywhere can benefit from these life-changing options. In addition to today's important announcements, I would like to highlight that the Journal of the International AIDS Society has published 3 new thematic supplements ahead of IAS 2025. These are PEP in Africa, Prospects, Opportunities, and Challenges. Expanding access to a choice-based HIV prevention market, and differentiated service delivery beyond HIV treatment for integration and other health needs. Each of these collections explores key challenges and opportunities that will help shape the future of our work to end the HIV pandemic. We have an outstanding panel of speakers with us today, and we will share more about these important who will share more about these important announcements. Each speaker will have 3 minutes for remarks. I will help keep us on time so that we can hear from everyone and leave the room for your questions at the end. Let's get started. So our first speaker is Dr. Saban Nazimana, the Ministry of Health of Rwanda. Dr. Nazimana, over to you for your official welcome. Thank you for being here with us.
Thank you very much, President of IAS, Beatrice. A pleasure to join this great panel of colleagues, friends. We share the same passion to end HIV, to end AIDS as a public health threat. So as a country, as a host country, we are very happy to join this press conversation, but also the conference. Since yesterday, from the exercise, the energy from Kigali Car-Free Day, the day and tomorrow. And it's a continued fight. We know what we have achieved together, and we know what can be done even moving forward with what the President of IAS just mentioned. We have better tools for prevention and treatment, and we have better ways to engage our communities, to fight stigma and discrimination, and integration within our systems, that we can not only achieve HIV control alone, we have also to strengthen our systems, our health systems. As a Minister of Health, as a government, as a host country for this IAS, we are very pleased to have you all, to have thousands of participants who are here in person and those who are connected remotely for this International AIDS Society Conference in Kigali, in Africa, where AIDS burden and other disease burden are still very high. And we must address these challenges, these problems, as quick as possible. So look forward to the conversation, the questions. I'd like to hand over to the next speaker. It's just to welcome you, and we'll discuss more on the question answers. Thank you.
Thank you so much, Dr. Nastanzi Mana. We are really thrilled to be here in Rwanda. Next, we will have Mary May, the Director of Data for Impact at UNAIDS. Mary?
Thanks, Beatrice, and thanks for inviting us to present here. UNAIDS has launched our global report, AIDS Update for 2025. The title is AIDS Crisis and the Power to Transform. This report describes how one of the most successful public health programs in recent history is being jeopardized by the cuts in funding. The report summarizes our latest data from countries on the global epidemic and the response, but it also goes further to look at what's happening in the last 5 months and what's happened with the funding cuts in relation to household services for countries and individuals. The HIV response has achieved tremendous progress. We shouldn't forget that. Since 2000, 26.9 million people have been saved, lives have been saved due to treatment. 4.4 million children remain HIV negative due to treatment to pregnant women. At the end of 2024, we estimate that 77% of people living with HIV were on treatment, and 73% overall of people living with HIV were virally suppressed, allowing them to live healthy lives and avoid onward transmission. This means that in 2024, we had a 40% reduction in new HIV infections and a 54% reduction in AIDS-related deaths. So considerable progress in the HIV response. However, we were still short of our global target point to make now in the response. So the second message about this report is really about the threat and the jeopardized situation of the hard-won progress in the response to HIV. In 2025, PEPFAR was scheduled to spend $4.3 billion on the HIV response. And in 2024, they provided 2.3 million adolescent girls and young women with comprehensive HIV prevention services. And 2.5 million people received PrEP, and 84 million people received HIV testing. These services are likely not to continue into the future and would potentially result in an increase in new infections. We recognize that this funding that's been so essential over the past years is threatening communities who provide the life-saving services to make sure people such as key populations or people who are stigmatized, such as people living with HIV, are getting the services they need. In 2024, only 50% services. UNAIDS has been collecting data on the service 2025. One of the examples highlighted in the PrEP for key populations in Nigeria. While before 2020, we were seeing monthly people starting on PrEP at 1,000 per year in Nigeria, per month in Nigeria. Started on PrEP, a huge drop in that service. Finally, the report goes on to recognize that countries and communities are transforming response, but global solidarity is needed. Forecasted budgets for 2025 of 60 low and middle income countries were planning to increase their domestic funding for 2020. So creating the fiscal space, reconsider tax reforms and debt reduction instruments, and build more development funding options is critical right now. So now is the time, is the challenging point in time when we are having to hear these heartbreaking stories from different presenters around the room about what's happened with the funding cuts. Now is the time to come together and serve and make sure we stand together to end AIDS. Thank you.
Mary, And our next speaker is Dr. Meg Doherty. Meg is the Director of Global HIV, Hepatitis, and STI Programs and incoming Director of Science, Research, Evidence, and Quality for Health at the World Health Organization. Meg will present us the new WHO guidelines on long-acting HIV prevention and treatment. Meg, the floor is yours.
Thank you very much, Beatrice. And we're just coming off of two really great satellite sessions. And I think we're all in the context of saying when we have a time of reduced funding for global health, how can WHO be putting out so many recommendations? But I believe at least two of them, and I'll speak about here today, are game changers and will help us in the simplification, but also looking towards efficient, equitable, and resilient health responses as we go forward. So one of our most crucial or critical recommendations that we offered and up today was around a new global recommendation on the use of lenacapavir as a long-acting injectable PrEP option, and its guidance on simplified HIV testing for the long-acting PrEP. These recommendations are part of a broader effort to support expanded access to person-centered HIV prevention, especially for populations at greatest risk. So that recommendation saying that long-acting injectable PrEP can be offered as an additional prevention choice for people at risk as part of combined prevention is a strong recommendation with moderate to high certainty of evidence. What does that mean? It means that the guideline development group looked at the evidence coming out of the Purpose 1 and Purpose 2 trials and found that this rated us strong recommendations with 100% efficacy for cisgender women in Purpose 1, 96% efficacy in key populations for Purpose 2. We believe this is an important new innovation. And safety was comparable to oral PrEP. Injection site reactions were frequent but mild. But as you know, this is going to be something we're looking forward to start implementing in early 2026. We believe this also helps to expand coverage for those who are not actually accessing oral PrEP or who are at risk, significant risk of HIV infection. And we also believe that it's going to be helpful in terms of turning the tide in countries that have reached 95 targets, as mentioned in the report, but still have significant new infections happening in young adolescent girls, in MSM, in key populations. This will be part of our solution to get to the end of AIDS by 2030. We also made a recommendation of using a rapid diagnostic test as opposed to nucleic acid tests. Why is this important? It is important because we know rapid diagnostic tests are available around the world, in Africa, in the region where we need this the most. It will allow for faster initiation, same-day access of long-acting PrEP, and will be more cost-effective. So as we go forward, we really want to see that every opportunity is taken to be able to take up the lenacapavir long-acting PrEP. We will be working with Global Fund and other partners as we start to bring this forward to the early adopter countries. I wanted to also mention that there are some forecasts now out there about how much long-acting lenacapavir PrEP will need in the future, and it's up to 4 million per year as we go forward. Again, we know this is just the start, and there will be more coming. I wanted to also turn to another important recommendation that we made, and we've shared just a moment ago about the first time we've made treatment guidelines around recommendation of using dual therapy, and in particular, dual therapy of using long-acting injectable cabotegravir and rilpivirine together as an alternative switching option for treatment in adults and adolescents for those who have achieved full viral suppression on oral antiretroviral therapy and who also don't have active hepatitis B infection. So this recommendation, we believe, is important for those who've had difficulty with adherence, can be life-saving, and we believe the evidence with a systematic review of 6 clinical trials have showed us that there's no difference in the outcomes and the efficacies, and we believe it can bring life-saving therapy to those who need it as we move forward. So let me just finish by saying that all of these guidelines are an important milestone for HIV prevention and for treatment, and we reconfirm our commitment to bringing forward innovations in science as soon as possible. So thank you very much.
Thank you so much, Meg. I would also like to take the opportunity to thank you for all your incredible and impactful work as the director of the Global HIV, Hepatitis, and STI program at the WHO. So our next speaker is Esteban Burrone. I am very pleased to introduce Esteban. He is the Policy, Strategy, and Market Access Director at the Medicines Patent Pool. Esteban will speak to us about a new licensing agreement to expand access to long-acting HIV treatment. Esteban, over to you.
Well, thank you very much. Very exciting to be here and to be able to speak right after Meg, who's announcing the new treatment guidelines of the WHO. I think today marks quite a significant milestone in the global effort to ensure equitable access to innovations in HIV treatment. Following the WHO's updated guidelines that have recommended, as Meg has explained, long-acting injectable cabotegravir in combination with rilpivirine long-acting for treatment, the Medicines Patent Pool and ViiV Healthcare are pleased to announce the extension of the voluntary license agreement for CAB-LA, cabotegravir long-acting, to now include the treatment indication as well. This builds on our 2022 agreement between MPP and ViiV Healthcare, where we signed a voluntary license for CAB-LA for PrEP. And this extension now, as I mentioned, will also include treatment indication with rilpivirine. This marks the first time that WHO recommends a long-acting injectable regimen for treatment. And it's also the first time that a long-acting treatment regimen becomes the subject of a voluntary license agreement. The license will enable our three generic partners, Aurobindo, Cipla, and Viatris, to develop, manufacture, and supply generic cabotegravir long-acting, both PrEP and treatment. It will enable access in 133 countries, which means all least developed countries, all low-income countries, lower middle-income countries, and sub-Saharan African countries, as well as countries where ViiV Healthcare does not have patent rights for cabotegravir. Importantly, the updated agreement also allows for supply in both public and private markets across the territory. This expansion would not be possible without a strong and sustained partnership with ViiV Healthcare. I want to acknowledge here today for their commitment to advancing access through voluntary licensing and the support they've provided to the manufacturers through transfer of technology and technical support. It also builds on the lessons of a long-standing partnership that we've had with ViiV Healthcare around dolutegravir, which has helped bring affordable DTG-based regimens to already 129 countries, reaching over 23 million people today. We're also grateful to Unitaid, MPP's main funder, and whose leadership and sustained investment in accelerating access to innovative HIV treatments and prevention tools in LMICs has been instrumental in making this milestone possible. Long-acting treatment regimens have been a long-standing ask from the communities, and I want to in particular acknowledge the key role of communities and their voice that has guided us throughout this process. This is a powerful demonstration that innovation and access not only should, but also can go hand in hand. And we're now going to turn our focus to supporting the development of quality assured, affordable products for both prevention and treatment. Our generic licensees have been working on the development of CAB-LA for PrEP, and this will give us a head start on accelerating the treatment pathway as well. We're going to work closely with them, with WHO, with regulators, with Unitaid, all partners, communities of people living with HIV, civil society, so that as soon as development happens and is completed and regulatory requirements are met, people in these countries have access to this product. This is about expanding the menu of options. Long-acting treatment offers a new way to support people's treatment journeys, especially for those for whom daily oral therapy isn't the best fit. The WHO recommendation is grounded in clinical data from diverse populations, and this license about turning that science into access. We must continue to strive for greater and faster access to innovation, recognizing the diversity of people's lives and ensuring that those most affected by HIV are not left behind. Today's announcement is a major step forward, and our work continues. We will invite and will work with governments, procurement agencies, donors, and civil society and communities to join us in ensuring that this innovation reaches the people who need it affordably, rapidly, and where it is needed. We have a list of partners here who are key to this whole announcement. I would like to mention today, of course, we have colleagues from ViV Healthcare here. They're available for comment and questions as needed. We have colleagues from Unitaid, and Unitaid, of course, will also, the Executive Director will be joining us later tonight. We have WHO, our generic licensee, Ceftlorobin and Viatris, our friends from the communities, Gerald Blimo from IREP, Kenya, Nombeko from the Desmond Tutu Foundation, the government of Botswana, AfroCab, and many others who have been supporting this announcement, and grateful to all of you. And thank you once again for listening to this intervention. Thank you very much.
Thank you so much, Esteban, for the great news. And our next speaker is Dr. Rebecca Plank, Distinguished Scientist in Clinical Research at Merck. Rebecca will discuss with us findings from the new study on the safety and pharmacokinetics of MK-8527, an oral once-monthly pill for HIV prevention. Rebecca, please, the floor is yours.
Good afternoon, everyone. On behalf of the study team, thank you to the organizers for the opportunity to participate in this year's press program. We are very happy that we will be sharing the results of our phase 2 study of monthly oral MK-8527. The data from this study show that doses up to 12 milligrams of MK-85 have safety and tolerability similar to that of placebo, and a pharmacokinetic profile that quickly reaches levels predicted to be protective against HIV, while at the same time making monthly dosing feasible. The findings from this study support moving clinical development into phase 3, the EXPRESSIVE program, consisting of 2 large efficacy studies. We are pleased to announce that for this phase 3 program, we will continue our partnerships with the Gates Foundation and with the International Clinical Research Center at the University of Washington in efforts to develop once-monthly oral PrEP. Until now, long-acting PrEP has been synonymous with injectable formulations, and the oral alternative of monthly 8527 could represent a paradigm shift. We hope that this option will provide a user-friendly, systems-friendly option that can be broadly available in a variety of settings. We envision that monthly oral dosing could transform PrEP delivery and implementation models. If the phase 3 studies are successful, this product could expand the range of delivery settings beyond medical clinics to locations that allow for flexibility and privacy. Monthly oral dosing could make it easier for people to obtain and to take PrEP. This would allow more people to start and to continue on PrEP, ultimately helping us reach our collective goal of ending the epidemic.
Thank you very much, Rebecca. We are all very much looking forward to the phase 3 studies. And now, finally, we are joined by Yvette Raphael from South Africa, Executive Director of Advocates for the Prevention of HIV and AIDS. Yvette will speak about the urgency of making long-acting HIV prevention and treatment truly accessible for all who need them. Yvette, please.
Thank you so much. Good afternoon, everyone. My name is Yvette Raphael, and indeed, this is a time for breakthroughs. However, the money is not breaking through. We are very excited and happy with the announcements made today, including MK-8527, the guidelines for lenacapavir, as well as long-acting treatment. All of this would mean nothing unless we do something different from what we know, the HIV prevention story that we currently have. Long-acting HIV prevention and treatment can only transform lives if people can actually get them. We cannot repeat the mistakes of the past where we have medicines that does not reach the people who need it the most. And that story is very much the HIV prevention story. We need a clear plan to scale up these medicines that are breakthroughs. We need funding commitments from our governments. We need to make sure these drugs are affordable in local and district level clinics, not only in spaces where our communities cannot reach. Science is overtaking us. Results after results is science giving us powerful tools, but we don't have powerful money. Now we all need to work together, community, governments, policymakers, and product developers to ensure these become available. According to BGBMC, by 2030, 11.6 million persons years of PrEP will be needed annually across four key populations, many of sex with men, female sex workers, transgender women, and people who inject drugs. Kerbele, Len, monthly oral pill, and now we hear about the monthly oral pill could meet only up to 60% of this need. And this can only be made possible if we are ready and we commit. As the African Women's Prevention Community Accountability Board, choice remains top of our agenda. We are not going to support only products as they become available, but as everyone mentioned here, a time for choice is now. Thank you.
Thank you so much, Yvette. Now we will open the floor for questions from the media. So for journalists in the room, please raise your hand and we will bring you a microphone. For those that are joining us virtually, you may type your questions in the Q&A feature and we will read them aloud. Please remember to share your name and media outlet and let us know if your question is directed to any specific speaker.
Murakoze nyakubahwa minisita nagira ngo yenda mu gisubizo mu kinyarwanda nagira ngo hashize igihe inkunga zifasha mu rwego zihagaritswe ese hari ingaruka byagize kuri uru rwego yenda mu rwego rwo kwishakamo ibisubizo harimo harakorwa iki gufatanya n'abafatanyabikorwa bandi nka societe civile. Hanyuma numvise ikibazo cya kabiri, numvise u Rwanda rushimwa cyane, ariko mu by'ukuri ni iki kimwe bibiri bitatu yenda mwumva biza ku isonga u Rwanda rwakoze bituma birimo u Rwanda rurimo gusubirwaho kenshi gutya? Murakoze. Ni Kwizera Bosco, RBA.
Thank you. I think the question was asked in Kinyarwanda. Maybe I can quickly translate for the others. He asked two questions. And the first question was about if implication of funding reduction, funding cuts to programs, to countries. What has this, what we see as an implication to Rwanda? And the second question was what we've done in our HIV response programs so that today we've reached these 95, 95, 95. So I'll be speaking in Kinyarwanda, maybe translate later quickly. So ikibazo warubajije cyuko amafaranga inkunga zagabanutse mu minsi ishize nibyo nta nubwo ari u Rwanda gusa byageze ku bihugu byose byinshi byabonaga inkunga harimo ntabwo ari ukurwanya sida gusa harimo n'izindi ndwara harimo n'izindi porogaramu. Icyo twakoze rero tumaze igihe dukora mu mezi bibaye ni uko iby'ingenzi bituma tudahagarika iyo dukora ibijyanye n'imiti, ibijyanye no gusuzuma, ibijyanye kugira ngo izo porogaramu zacu zitazahagarara, byose byarakozwe ndetse dushakisha n'uburyo ibyatwaraga amafaranga menshi bikorwa mu buryo bitwara make kandi tutabihagaritse. Ntabwo twigeze duhindura intego zacu, nta nubwo tuzabikora, ahubwo turashaka ibindi bisubizo bituma tugera ku byo twagomba kugeraho nubwo inkunga zagenda, kuko n'ubundi ntabwo zizahoraho iteka ryose. Ngira ngo icyo nicyo cyakozwe kandi niko gahunda ya leta y'u Rwanda ikomeza no mu bindi. Ku cya kabiri warubajije ibyo twakoze mu kurwanya sida kuva byatangira, gukoresha neza n'izo nkunga ariko no gushakamo ibisubizo natwe ubwacu. Twagiye rero tutakora serivisi zo kurwanya sida ziri ku ruhande, ahubwo ziri muri gahunda zindi zo kubaka urwego rw'ubuzima, ibyo bita integration mu rurimi rw'icyongereza. Byaradufashije rero ko ntabwo twabonaga ibyo kurwanya sida byaba bitandukanye n'ubundi no kubaka urwego rw'ubuzima. Uburyo tunitegura n'icyo gihe ibigenerwa porogaramu runaka bihagaze urwego rw'ubuzima rwo rugakomeza rukomera. Indwara iyo ari yo yose twahangana nayo, icyo ni nacyo gikuru. Ikindi ni ubushake nyine n'imikoranire y'inzego, kandi byagiye bitanga umusaruro. N'abafatanyabikorwa n'aba bari aha ngaha kuba baje mu Rwanda hari icyo bidusigira, haba mu bumenyi, haba no mu bindi, ndetse namwe n'abakora imirimo yabo, abacuruzi n'abandi, nabo hari icyo biri buze kubasigira muri make. Murakoze. Thank you.
Roger Pebbody from AIDSmap. My question's for Esteban Baroni. So you spoke about the voluntary license for cabotegravir for treatment, but obviously that's 50% of the regimen. So for this to reach the people who need it, as you said, surely you need a license for ripivirine as well.
Thank you very much. So as you rightly said, the recommendation from the WHO is on the combination of cabotegravir with rilpivirine for treatment. Our agreement with ViiV Healthcare, of course, covers the cabotegravir component of this. With respect to rilpivirine, it's a relatively older drug. The compound itself is off patent by now in most countries, and the remaining patents in the few countries that they still have, because Janssen has indicated it would not be enforcing patents in a number of countries. Wherever the few patents that remain will be expiring soon over the next couple of years. So by the time generic manufacturers would be coming to market, we don't expect there to be any real need for a license for that component of the treatment regimen. Thank you.
Thank you. We have a few questions online that I'll read out. So on behalf of Esther Nakazi from Uganda, the question is to Dr. Saban. Where is Rwanda at on the rollout of lenacapavir? Where is Rwanda at on the rollout of lenacapavir?
We are interested. I mean, haven't yet started, but I think this is something we are considering. There's a number of planning and discussions and collaboration we're building around this. So look forward to begin as soon as all these consultation agreements are in place.
Thank you. And a couple of questions online for Rebecca. So we have Fred Lebreton from Remaids in Paris. The question is, have you observed any side effects in people who have taken MK8527? If so, what were they? And the second question from Liz Heileman at POS and AIDSmap is, do you have a sense of the timeline when monthly PrEP could become available? So to repeat, the first question is about side effects. And then the second question is a sense of the timeline.
Thank you very much for those questions. I'll address the side effects one first. The most common side effects that were seen in any arm of the study were nausea and headache. And the side effects that we saw were distributed same throughout the 3 treatment arms. There were 3 milligrams, 6 milligrams, 12 milligrams, and placebo. So the percentages of people reporting these side effects in the 4 arms was similar. Importantly, I want to point out that I don't know, people will hopefully still come to our presentation on Wednesday afternoon to see the full results presented by Dr. Ken Mayer. But the lymphocyte count, importantly, was also the same as placebo, even at the 12 milligram dose for 6 months. I think that may have been part of her question. And then with regard to the timelines, we plan to start these studies fairly soon in the fall. Both of the phase 3 trials should start then. And the timelines, it's hard to say exactly what they will be because we have yet to begin the studies, and the timelines will depend on how quickly they enroll and how quickly the projected endpoints are reached. But we hope to be able to make this available as soon as possible. We are pursuing very optimistic and aggressive timelines.
Thank you so much. My name is Sarah Jerving. I'm a journalist with DevX. My question is about key populations and the U.S. funding. Given the Trump administration's executive order around diversity, equity, and inclusion, do we anticipate that any U.S. funding moving forward through PEPFAR or other means would go towards programming targeting key populations, or would that be out of the question? And what are the implications of that? Thank you. And I think whoever wants to take that on.
Yeah, so I think it's an important question. It's one, you know, just to be honest here, it's one that you should be asking to the PEPFAR program. But I think our understanding is that there will be cuts in those programs, and to the extent that we can make those programs targeted. So when we think about rollout of PrEP, if we can target programs geographically instead of to key populations, or if we can find other ways to target programs to make them accessible, those programs that are funded by the US government. But it also means it's a time to really push up the funding for prevention and key population programs from those domestic resources as well. So that diversification of funding sources is important, but then there's also the ways of looking at how we use that US government funding that hopefully will be there and use it in a way to reach those populations most at risk of HIV. Thanks.
Murakoze cyane. Nitwa Jean Desire Igize neza, ndi umunyamakuru kuri igihe.com. Nashakaga kubaza ikibazo cyanjye Minister. Hashize igihe kinini tubona umuti wa sida, ukabona ntawuboneka, n'ubonetse ngo ni mu mezi 6. Ese ni izihe mpamvu tutagira umuti wa sida ngo tuyibone wenda ko ushobora gufasha mu kugira ngo umuntu ajya nk'umuti nyine uhite umuvura nk'uko twabibonye kwabigenje kuri Marburg, nk'uko twabibonye twabikoze no ku zindi ndwara. Ikibazo cya kabiri mfite ni uruhe ruhare rw'u Rwanda mu bushakashatsi bwo kurwanya sida? Ese hari ubushakashatsi twebwe nk'abanyarwanda dukora aho kugira ngo twende tube turirahinga ku banyamahanga cyangwa turirahinga ku bandi? Twebwe ubwacu hari ubushakashatsi twaba twarakoze buri unique bushobora gufasha mu kurwanya virusi itera sida, cyangwa hakaba hari ubundi abanyamahanga nabo bashobora kuba barifashishije amakuru yacu mu kurwanya iyi ndwara? Kirajyana n'iki cya gatatu kibabaza ngo ese muri guteganya iki kuri uyu muti mushya ugiye gukoreshwa cyangwa wakoze n'Abanyamerika ugiye gutangwa mu mezi 6? Twebwe nk'abanyarwanda turateganya iki? Abanyarwanda ukeneye bashobora kubona gute? Ni iki guverinoma y'u Rwanda iri gutekereza? Murakoze.
Thank you. And Dr. Saban, if you don't mind, we have international and global media here. So if you don't mind summarizing the question, and then if you could give your answer also in English in addition when you respond, is that possible?
All right, with pleasure. So he asked 3 questions in Kenya. One was on antiretroviral availability. The second was on the role of Rwanda in the global research on new medications and new HIV initiatives. And the third one is about long-acting treatments and what are we doing to get this into our treatment protocols. So maybe let me start answering in Kinyarwanda so he can get his answer properly. Ikibazo cya mbere warubajije ku miti itaboneka cyangwa idahari, agomba kuba ari amakuru tudahuje neza, kuko imiti ntabwo, nubwo hari inkunga zahagaze mu kurwanya indwara zitandukanye mu minsi ishize, ariko ibijyanye n'imiti yo kuvura cyangwa se guha abana na virusi itera sida yo ntabwo imiti yigeze ibura. Haramutse hari aho itari, ubwo mwatubwira. Umuti ukiza burundu. All right. So he made clarification. It's not ARV's availability, it's actually the treatment to cure AIDS, to cure HIV. Why there's no treatment to cure HIV? I think there are more experts in this field who will address that to complement. But hari abari bubisubize kurushaho, bari no kubikoraho ubushakashatsi, nubwo nabikozemo ariko ntabwo bizi cyane nkabo. Icyo numva kiri buze gusubizwa. Icya kabiri ni ikijyanye n'uruhare rwacu mu bushakashatsi ni runini, kuko niba ubizi neza tumaze hafi imyaka 20 dufite ikigo gikora ubushakashatsi cyatangiye no gikora no kuri bijyanye n'inkingo zishobora kuzavura HIV. Ushobora kuba warakuze wumva ikigo cyitwaga San Francisco, na n'ubu kiracyahari. Kiriya ni kimwe mu byakoraga ubushakashatsi mu Rwanda. N'ubu ngubu rero turacyagira natwe uruhare mu bushakashatsi mpuzamahanga mu bijyanye na sida. Nayo mpamvu n'ubu baba bagize n'icyizere bakavuga bati aha ngaha tuhahuriye hari ibyo turuze kuganira n'abantu baho ndetse n'abantu tuhahurira. Icyo cyo kirakorwa kandi kizanakomeza. Icya nyuma ni ku miti, turava ku kinini, twavuye ku binini byinshi abantu banywa ku munsi tujya ku kinini kimwe ku munsi, ariko mu makuru mwumvise aha ngaha ni uko turi kujya noneho ku muti abantu bafata yabo wo kunywa, ugafata umuti wo kunywa w'ukwezi rimwe, cyangwa se ugafata urushinge rw'amezi menshi, ushobora kugera no ku mezi atandatu. Ibyo byose nibyo byagarutsweho aha ngaha, ni nabyo bizagarukwaho muri iyi nama. So I would like to briefly speak about my answers in English. So he asked about the treatment to cure, which will be addressed by the experts who are better equipped to speak about this. I mentioned that I've been in this field for many years, but I keep the answer to the experts to address this. But his question on research, I mentioned our role into research in this field of HIV. I mentioned the different trial sites we've been running the past 20 years on vaccines, on new treatment, and what we continue to do moving forward as a country, but also as a continent. And on long-acting treatment, I was responding to him that we moved from daily tablets to a single pill per day. Now we are moving towards treatment that can cover not daily, but months, including injectables that will be in the new protocol guidelines that we may have soon in our treatment options. Thank you.
Good afternoon. My name is Lucie Mouillot. I work for Radio France International. My question goes to Mr. the Minister. Sorry, I think you replied in Kinyarwanda to that question already a little bit, but if you could explain in English about the global funding cuts. What was the impact in Rwanda of those funding cuts, especially for the 10,000 people using PrEP in the country? And what was the response of the government to this? Thank you.
Thank you very much. I didn't expect to receive more questions, but we'll be sharing. But since we are in Kigali, in Rwanda, I'm very happy to take these questions. So the funding cuts affected many countries, and Rwanda is among a number of countries that were affected. So it came, I would say, as a surprise that we started, like many other countries were affected, to plan how do we deal with this situation. And the first thing was to prioritize our programs and our interventions by most urgent, important, nice to have, and probably not urgent for now. We delayed a number of activities were funded through this scheme, but also finding ways to integrate what we've been doing through our health sector. So that, at least for now, has worked. And we kept most essential, most important interventions to continue, including treatment, including diagnostics, including personnel. And we're also leveraging on technology to do some other interventions differently, like trainings, moving more into remote, into tele teaching, into mentoring without moving people from places to places. So this is the major, the funding cut, the microphone cut. So other than that, we're also raising more funding from domestic, from our treasury. There's a number of financing that we had to wait and connect with our financial year, which is started July 1st. And so far, we haven't changed our goals, and our targets remain the same across all programs that were affected, mostly malaria, maternal child health, HIV program at some extent. And we believe that this was also an opportunity to see how we can get prepared to any other future pressure of this kind. And in my answer before, I said you can't prepare this when it happens. You also think about it 10 years back. For example, in 2012, we've been integrating all our HIV programs within the sector programs from top to down. That's how RBC was merged from 14 programs, HIV, TB, malaria, mental health, all coming together into one institution to cut a lot of administrative costs of vertical programs down to district hospitals, services integrated within routine care, and down to the community. That helped to save a lot of money. At the same time, the financing through these disease programs helped to strengthen the system, which has at least prepared us as a country to the situation probably, which is much harder to some other countries who are facing maybe a bigger burden of cuts.
Thank you. My name is Denise Babazi Mambara. I work for African Updates. I want to ask, you mentioned about these new shots that protect against HIV, and I want to know how soon can people here in African countries get it? And again, I want to hear from you, what challenges do you think or do you see in getting it to everyone who needs it, especially with these recent funding cuts? Anyone can answer. Thank you.
Yeah, I can start first. Yes, so the lenacapavir injectable PrEP, we launched guidelines on this today where FDA already has qualified it. WHO pre-qualification should happen very soon after the EMA makes their judgment, and the EMA is the European Medical Association. What the plan is right now is that the lenacapavir PrEP will be available in countries starting in the beginning of 2026. It will be starting with certain countries that have been identified as what we call early adopter countries, because we know that they have a system already set up to receive injectable PrEP. They've been using cabotegravir long-acting, for example. And at the beginning, it will be rolling out in much of a targeted way to those who are going to benefit from the most from injectable lenacapavir PrEP. But with the idea that when the generics become available, which will be in 2027, even late 2026, perhaps, when the generics become available, that there will be even a greater ability for more countries to bring lenacapavir to the countries. So some of the challenges, I would say, is ensuring that we have the system set up well, whether it's supply chain, whether it's training of human resources, whether there's demand and that people are interested in accessing it, and ensuring that the clinics that may have been affected by some of the funding cuts are either moved, maintained, or restarted to be able to deliver lenacapavir PrEP. There are many clinics that could be doing this and many healthcare workers who could be doing this, whether they're HIV clinics, whether they're sexual health clinics, or whether they're clinics that are specialized for key populations. Thank you.
Yvette, would you like to add anything on this? Thank you.
Thank you. My name is Alice Omotesi. My question goes to the Minister. Minister, yesterday during Carefree Day, you mentioned that HIV is still a threat among young people. So I would like you to elaborate more on this. And if you also have recent data to show this trend, it would be helpful. And also, we know there used to be initiatives, awareness initiatives, the use of condoms in schools, in public spaces, especially roads. What happened to that? And as you end, you can end with a call to action. What can be done to reverse this trend? Thank you.
Thank you. It's true that in our own data, and I looked at international data as well, new infections among the young people, among youth, 15 to 24, that's the category actually we see more new infections. And particularly in our country, when you compare even districts and provinces, you look at Eastern Province having more higher new infections. That is from our data. So, and the awareness, as you mentioned, is important, but also availing these tools that we are talking about is equally important. We can't do one without the other. So the call for action is exactly what you said. It's important to recognize that HIV is still there, and young people are more affected in infections, and they are not getting actually infection from the mostly from older people, which is also that age connectivity and key populations that we talked about. So those are key messages. So we'll probably be talking about this more through this week and other engagements. But prevention is still important, even if we have better treatment options. Prevention is the first line of defense against HIV. Using condom and consistently will help to save these infections, but also protect and save money as well. Thank you.
Thank you very much. Esteban, I have a question for you. Do you foresee do you have any expectations that this license could be expanded to other countries that are currently not covered, neither for PrEP nor for antiretroviral treatment now with CAP?
Thank you, Beatrice. At the moment, the license, as I was mentioning, covers all low-income countries, all lower middle-income countries, all of sub-Saharan Africa, least developed countries, and then there's a whole range of additional countries where ViiV does not have patent rights that will be able to also get access, and that brings it up to about 133 countries, which is probably the widest, at least I'm aware of, in terms of the reach of a voluntary license. Of course, we're always willing to continue to explore where there are opportunities beyond that. But I think, I think right now the big focus is going to be, can we get these products developed rapidly? Can we get this regimen actually out there, approved and rolled out? And what is that rollout going to look like? I mean, it's the first time there's going to be an attempt to roll out injectables, long-acting injectables for treatment, and it's not. There are a whole range of challenges that will come with it. I think we need to be aware of that. But I think it's also quite an exciting and an important milestone for a lot of people who've been asking for this for a very long time.
Yes, it's tremendously exciting, but unfortunately, many countries that have high incidence, specifically among key populations, are left behind. So just a note. Thank you. Any other questions? No. So thank you so much for all our speakers and everyone who joined us today, both in person and virtually. The science and commitments announced today give us real hope, even in these unprecedented times, and reminds us of our shared responsibility to ensure that cutting-edge technologies are affordable and available to people everywhere. If you have any additional questions or wish to request any interviews, please contact our media team. And thanks again. I wish you a very productive conference.
Record